Okay, good morning and thank you again. We have no disclosures, but this work was supported by a grant from the Department of Defense 711th Human Performance Wing of the United States Air Force. Tissue-related damage related to trauma as well as hemorrhagic shock can lead to a rightfully feared unhinging of life known as the acute traumatic coagulopathy. This can lead to increased transfusion requirements, more days in the ICU on the vent, more multi-organ dysfunction, as well as 3 to 4 times increased mortality and an 8 times more likelihood of dying within the first 24 hours. We know that the best way to combat this is with a balanced massive transfusion resuscitation protocol, and we also know that the most common cause of preventable death is from insanguination. However, these two things do not marry, as massive transfusion practices are impractical in the field for these reasons here. Difficult to store, difficult to transport. There's no real ability to prepare or store plasma, issues with blood typing, as well as concerns with disease and tissue and transfusion reactions. For these reasons, factor-based resuscitation has been thought of as a potential way of mitigating those problems. They are easy to transport, such as prothrombin complex concentrate as well as TXA. They can be universally given, they're fastly administered in low volumes, and they may be able to correct coagulopathy. We hypothesize that these factor-based resuscitation methods may have actually varying effects when used in a trauma-induced coagulopathy. We set to evaluate the effects of these different resuscitation methods on the hemodynamics as well as reperfusion injury and coagulopathy in our validated acute traumatic coagulopathy model. We begin by pre-placing lines and a 35% total body hemorrhage. This is followed by a supraceliac cross-clamping for a 45-minute period to induce reperfusion injury. The cross-clamp is removed over a 5-minute period to allow that reperfusion injury to happen, at which point our resuscitation with either plasma, a combination of plasma and our drugs or drugs alone was given. Animals were, there was a total of 46 animals actually studied. They were randomized to one of 6 groups, either a single drug being given or a combination of those drugs, as you can see here. Data was collected at baseline 1 and 4 hours for hemodynamics, laboratory values, including pH, lactate, and coagulopathy, coag laboratory values, as well as rotational thromboelastography. Our analysis was completed using a MANOVA testing and Tukey post hoc between all 6 groups. We also attempted to correct for differences in baseline by using the absolute change over that period of time. And there was also a subgroup analysis of all FFP containing groups pooled together, comparing those to non-FFP containing groups. We found that all animals had evidence of hemorrhagic shock with increased heart rate, decrease in the MAP, as well as a decrease in the hematocrit. Acidosis was also seen in all animals with significant increase in lactate and corresponding decrease in pH. We also saw a consumptive coagulopathy in all animals with a decrease in platelets over time and a significant hyperfibrinolysis or a decrease in fibrinogen levels. We first looked at TXA alone and compared that to TXA and FFP for our endpoints and found that for hemodynamic purposes, TXA when put with plasma had higher levels of mean arterial pressure at the end of the resuscitation with more physiologic central venous pressures as well as pulmonary artery wedge pressures. Acidosis in terms of the amount of lactate in the serum was also significantly better when TXA was combined with FFP, and coagulopathy also appeared to be improved with a decrease in hyperfibrinolysis in the TXA-FFP group, that being lower levels of fibrinogen in the TXA alone group, with faster clotting times, firmer clots in the TXA-FFP group, and less max lysis on rotational thromboelastography. When PCC was looked at the PCC plus PCC and FFP, we found similar results, with our CVP being significantly lower in our PCC-FFP group and our systemic vascular resistance also being more physiologic. When FFP was added, lactic acidosis was again curbed in such a way that it was statistically significant from PCC alone. And again, our coagulopathy was improved with PCC plus FFP, with fibrinogen levels being significantly higher, clotting times being faster, and max lysis being significantly less. Importantly, we found that 1/4 of our PCC alone animals demonstrated laboratory values that were consistent with DIC. We also compared TXA plus PCC. We found that, again, hyperfibrinolysis was worse in the TXA plus PCC group, and there were no difference for hemodynamic or other rotational thromboelastography values. When looking at fibrinogen levels as a percent change from baseline over the 4-hour period, we found that there was an increase in fibrinogen levels in all of the groups excepting PCC and TXA PCC. Those are actually negative and not showing up on the graph. Oh, here we go. Since our data showed favorable outcomes for our FFP, we decided to pool that data to see exactly how favorable it was. We found that lactic acidosis as a change from baseline to 4 hours was significantly improved with the FFP-containing groups. This was also seen for fibrinogen levels at a 4-hour period, although same at baseline. There was a much higher fibrinolysis in the non-FFP-containing groups, and that clotting time was significantly faster in our FFP-containing group. We were, of course, limited by similar limitations as we've mentioned previously in our animal studies. It is a controlled hemorrhage, which makes it a not dynamic process. This is a coagulation study in a notoriously hypercoagulable animal, so that obviously limits our findings. If you're interested in ways that we curb that, I'm happy to answer those questions. And there are genetic variability in the research animals. We found worsened outcomes with PCC or TXA alone with improved hemodynamics, lower lactate levels, a decrease in fibrinolysis, and improved clotting time when FFP was added. From this, we can conclude that there is no clear benefit of using PCC or TXA either individually or in combination with each other, and that further studies validating the efficacy and safety of a factor or a purely factor-based resuscitation method should be implemented before routine use is employed. Thank you, and I'd be happy to take any questions.